reducing their effect by making a cytoprotective lining in the GIT as well as in the duodenum, are acting by three different mechanisms. They are acting by increasing the pH of epithelial lining by increasing production of bicarbonate. This is the one mechanism. Second mechanism, that they increase the mucus secretion that will synthesize a layer in the GI tract and provide a healing and protective effect. Third mechanism of mucosal protective agent is to increase the synthesis of PGE2 and PGI2. PGE2 is providing a mucosal protective lining, and PGI2 is what it is doing. PGI2, if the HCl which is produced and producing ulcer, so the severe condition is when it is transferring into the severe condition, it ultimately damages the lining inside the GIT, which results bleeding. So it can control bleeding by increasing platelet aggregation. I had shown you a picture in the slide last time in which I told you and I presented three different compounds and three different receptors which are acting and involved in HCl production last time when we were discussing H2 receptor antagonists. Along with that, I told you that there are two receptors. One is of somatotropin receptor, another one is of prostaglandin receptor. These two receptors are acting to accelerate GI, that is the inner messenger system or a cyclic system, which is ultimately activating G protein I. It is an inhibitory protein, and this protein is acting to block the effect of or synthesis of cyclic AMP. These proteins are acting to block cyclic AMP. So ultimately, when cyclic AMP, which is going to produce a positive effect on potassium and hydrogen ATPase enzyme, will diminish the production of HCl. So this is basically the mechanism of cytoprotective agent. I cannot show you the picture. There is another slide, and this slide is revealing that what is basically the mechanism of most common cytoprotective agent, that is Sucralfate. Sucralfate is producing its effect by four different mechanisms. One, it is enhancing mucus secretion. The second is it is increasing prostaglandin synthesis. Third is it is increasing bicarbonate synthesis, and fourth is it is increasing the synthesis of growth factor, and all these different mechanisms are ultimately providing a cytoprotective layer within the GI tract that can minimize the effect of HCl and that will provide protection against HCl effect. Now come to the drugs which are listed in listed as cytoprotective agent, which are used for the treatment of peptic ulcer disease. These are classified into two different classes. The first class is mucosal protective agent, and the second class is PG's initiator, or those drugs which are increasing synthesis of PGs. Mucosal protective agents are comprising of colloidal bismuth and sucralfate. Colloidal bismuth and sucralfate. While PGs, which are also acting to provide defense to the mucosal lining. There is only a single agent, it is misoprostol, M-I-S-O-P-R-O-S-T-O-L. P-R-O-S-T-O-L. So up to now we have discussed the mechanism by which these agents, which are called as and named as cytoprotective agent, they are acting, and we have classified the drugs in this class of medication. We are starting with sucralfate. If we talk about chemistry and pharmacokinetics, sucralfate is a salt of sucrose complex to sulfated aluminum hydroxide. It is a salt of sucrose complex to sulfated aluminum hydroxide in water or acetic solution. Keep remember, in water and in acetic solution, it forms a viscous paste that binds selectively to the ulcer or erosion for up to 6 hours. It is basically the mechanism of action of sucralfate. That how it acts in acidic condition as well as in water. It binds with the surface. Which type of surface? Not the normal surface. The erosed surface of GIT lining, which is due to excessive HCl production or necrosis has been occurred. So this sucralfate acts in the presence of acidity with the erosive lining. When we talk about dynamics of sucralfate, a negatively charged sucrose sulfate binds to positively charged protein in the base of ulcer or erosion. It is a negatively charged, sucralfate or sucrose is a negatively charged. What it will do, it bind to the positively charged protein. Protein कैसे? Negatively charged sucrose sulfate binds to the positively charged protein in the base of ulcer or erosion, forming a physical barrier that restricts further causative damage. It stimulates mucosal prostaglandin as well as bicarbonate secretion, which we had just discussed. Now come to the dose and clinical uses of sucralfate. About 1 gram 4 times per day on an empty stomach. In an empty stomach is given at least 1 hour before meal. The recommended dose is 1 gram 4 times per day on an empty stomach, that is given 1 hour before meal. The upper GIT bleeding is in critically ill patient or hospitalized in the ICU, although it is less effective than IV H2 antagonist. जो मैंने कहा था कि जब critical situation होती है, critical situation में definitely the person should be in the ICU and hospitalized. So although H2 antagonists which are given IV are the main drug that is given to control, but still it can be given, sucralfate can be given to protect the acidity damage which is occurring in the GI tract. It is also useful for the prevention of stress-related bleeding because of the concern that acidity inhibitory therapies, for example, antacid, H2 receptor antagonist, and PPI may increase the risk of hospital-induced pneumonia. Okay? Treatment will be considered as to give for the treatment of acute illness. by IV or by parenteral route of administration. Important thing is that for the prevention of stress-related ulcer, if we ask a patient to go to hospital and hospitalize there and take the medication H2 receptor antagonist, antacid or PPI, so there are chances of hospital-induced infections. Chances बढ़ जाते हैं. So best is that the person should be treated at home by giving Sucralfate for the prevention. ठीक है, start में लेना शुरू कर दें ताकि damaging and interaction, drug-drug interaction. The drug-drug interaction and adverse drug reactions are minimum or rare. As it is, why these are rare? The use of Sucralfate due to the presence of aluminum hydroxide is although the drug-drug interaction within the hepatic circulation is minimal or negligible, but still due to the synthesis of protective lining, it can decrease the absorption or it can delay the absorption of certain drugs which require HCl secretion. ये हो सकता है. So what we will do strategy in that case, we can change the dosing time or administration time of two drugs. Is this clear? Okay, now come to bismuth colloidal compounds. Bismuth colloidal compounds. Two bismuth compounds are available currently. One is bismuth subsalicylate, a non-prescription formulation which is containing bismuth and salicylate. One is bismuth subsalicylate, a non-prescription formulation that is comprising of or that is containing bismuth and salicylate, while the other one is bismuth subcitrate. Bismuth subcitrate potassium. In USA, bismuth subcitrate is available only as a combination prescription or preparation. In USA, bismuth subcitrate potassium, it is available only as a combination product which contains metronidazole and tetracycline. So what type of treatment can be done by using this combination? Now you read salicylate undergoes rapid dissociation within the stomach. The first compound, bismuth subsalicylate, I say that it will undergo rapid dissociation within the stomach and allowing absorption of salicylate. While 99% of bismuth type of compound will be eliminated in the stool. Now come to the dynamic or mechanism of action of bismuth type of compound. They coat ulcer and erosive lining. They coat ulcer and erosive lining by creating protective layer against the acid and pepsin. It may also stimulate, this is the one mechanism, it may also stimulate prostaglandin, mucus and bicarbonate secretion. A similar type of mechanism which we have discussed with Sucralfate. A similar type of action which we have discussed for Sucralfate. Bismuth subsalicylate reduces stool frequency and liquidity. It reduces stool frequency and liquidity in acute infectious diarrhea. In acute infectious diarrhea, one of the important function of bismuth compound is that it acts as a direct antimicrobial effect. It produces direct antimicrobial effect, due to which it is beneficial in preventing or treating traveler's diarrhea. It is useful for the prevention of traveler's diarrhea. For the non-specific treatment of dyspepsia and acute diarrhea, this medication is recommended. For the non-specific treatment of dyspepsia and acute diarrhea, for the treatment of traveler's diarrhea or in motion sickness, 30 ml or 2 tablets 4 times daily given. For the treatment of traveler's diarrhea, 30 ml in the liquid form, while 2 tablets 4 times daily can be given. While in peptic ulcer, which is associated with H. pylori infection, peptic ulcer which is associated or which is due to H. pylori, it is used in quadruple regimen, and the dose is 2 tablets of 262 milligram each. 2 tablets, 262 milligram each is given. As far as its adverse drug reactions are concerned, it is considered as an extremely safe medication. It is considered as an extremely safe medication. The problem that arises is the blackening of stool or increasing the color of stool, which may confuse with the gastrointestinal bleeding. And if the patient is using bismuth type of compound, the stool color will dark but never mix it with the peptic ulcer bleeding. Liquid formulation may cause harmless darkening of tongue. This is the second adverse drug reaction, but not associated with the tablet form, but with the liquid formulation. While if the person is using for the prolonged period of time, then certain minor type of reactions or adverse reactions can be observed, including ataxia, headache, confusion and seizures. Ataxia, headaches, confusion and seizures. Now come to the second class of medication in cytoprotective agents, that is prostaglandin analogs. The primary prostaglandin analogs including PGE and PGF, misoprostol, which is a methyl analog of PGE1. The oral form of misoprostol is rapidly absorbed and metabolized. Oral form of misoprostol is readily metabolized and absorbed to a metabolically active free acid. The serum half-life is less than 30 minutes. So what will happen if the serum half-life is too short? We need what? If the serum half-life is short, what will be the drawback of medication? Yes, multiple doses are required to maintain the level within the GI tract. So at least 3 to 4 times daily administration is required. Very good. It is excreted in urine. It is excreted in urine. While dose reduction is not recommended in case of any renal insufficiency, because it can eliminate through glomerular filtration easily. So the dose reduction is only required for those medications which are either reabsorbed in case of renal insufficiency, or those cannot pass through the glomerular filtration easily. These are having the big size particles. So they cannot pass glomerular filtration, and ultimately their concentration will increase in the body, which may lead to cause toxicity which is associated with that medication. Or we can say that the exertion or overactivity of adverse drug reaction. So in that case, although the drug is eliminated through urine, but minimization of dose is not required in case of renal insufficiency. Misoprostol has both acid inhibitory and mucosal protective action. Misoprostol has both acid inhibitory. अब acid inhibitory कैसा है? If you recall the mechanism or that picture which I showed you in H2 receptor antagonist, and also in this slide, the incidence of ANSAID-induced ulcer, and it is approved for the prevention of ANSAID-induced ulcer in high-risk patients. It is approved for the prevention of, keep remember prevention, not for the treatment, for the prevention of. Why? Because it can reduce the incidence in less than 3%. It can reduce the incidence in less than 3%, but it can minimize the complication up to 50%. For that reason, it is used, better is to use for the prevention rather for the treatment. Is this clear? Although it is used in the high-risk patient, however, misoprostol is not a good choice. It is not a good choice due to its high adverse drug reaction profile. And need of multiple doses. Always in the drug delivery, compliance of patient is the major part of formulation. So if the repeated doses are required, patient compliance will decline. Patients will always prefer to take a single dose medication once in a day, which can be memorized easily and which can be administered easily, rather to give multiple doses. क्योंकि उसका टाइम याद रखना, उसको बार-बार लेना, और कहीं मूव कर रहे हैं, आजकल के इतने एडवांस और बहुत ही एक्टिव डायनामिक टाइप के इरा में बोतल लेके तो नहीं घूम सकते, हर वक्त दवाई भी नहीं खा सकते, तो आपको चांसेस होते हैं कि आप उसका जो डोज है वो स्किप कर दो. सो इस वजह से इसका यूज जो है वो इतना ज़्यादा नहीं है. As far as the doses are concerned, 100 to 200 microgram orally given after every 6 hours, and it is given along with the food. This medication is only recommended to those who can tolerate the diarrhea induced by it. Those who can tolerate diarrhea induced by it. So in case of or due to the diarrhea, 100 microgram after every 6 hours is recommended, while it is not recommended for the children under the age of 8. It is not recommended for the kids children under the age of 8. Most common adverse effect or the major adverse effect is diarrhea. The second one is abdominal pain, headache, abnormal heartbeat, chest pain, hearing loss, heart attack, nausea and vomiting. Well, today I gave a quote of the day that don't fall into trap of such shaitan, who makes you believe that happiness comes with the getting all